All right, guys, our next topic is toxicology. And toxicology is very important because you'll definitely see it in clinical rotations, and some of the principles that it involves is highly tested. So I wanted to start with basic principles of toxicology. So there's the general principles of A, B, C, D, E, F. And these are some basic principles to think of when you have a patient who has overdosed or has some sort of poisoning. So the first three things that you want to think um, of any patient before you start thinking about the toxin is ABC, the airway, breathing, and circulation. And definitely on step one for or even New World questions, they'll try to trick you and they'll try to get you to do something before the ABCs. So the first thing is airway, second thing is breathing, and then third thing is circulation. Um, so after you've stabilized the patient, you made sure that they have an intact airway, that they're breathing appropriately, and that they have a pulse and their pressure is maintained. You want to start thinking about what they've ingested or what poison they have. So that's where the D, E, and F come. So D is decontamination. So decontamination is pretty much trying to get out what the patient has ingested, and this is mainly for oral toxins. Best best indication for decontamination if the patient has presented early and preferably within the hour. Patient also must have protected airway because in decontamination, what you're doing is that you're giving the patient something orally to clean their gut because the toxin is presumably still in their gut or in their stomach. So you have to have a protected airway. So either the patient is intubated or they are awake and alert and they can respond to you appropriately. Because when you're giving them something through their mouth, you have a risk of vomiting and aspiration. So the three strategies for decontamination is three things: activated charcoal, gastric lavage, and whole bowel irrigation. So activated charcoal is a medication that binds to medications or toxins, and it's pretty much a binder. So you give it to the patient orally, and it binds to the toxin, and it gets excreted through the feces. The thing with activated charcoal is patient must have normal peristalsis. If you don't detect bowel sounds on the patient, it is contraindicated to give activated charcoal because you have a risk of obstruction. So that's the first method of decontamination. The second method of decontamination is gastric lavage. And gastric lavage is just a fancy way of saying I'm going to clean the stomach. So we put an NG tube in the patient and then we flush fluids in, usually normal saline, and then we flush it out. And it's really useful if the poison is metal because it's easily flushable. The third method of decontamination is whole bowel irrigation. And whole bowel irrigation is giving the patient an osmotic agent like polyethylene glycol. And if you remember from the GI lecture, polyethylene glycol is a medication used for constipation and it just draws water into the gut lumen. And by doing that, it flushes out the GI tract. Whole bowel irrigation is useful if the poison is caustic agent, that means if it's acidic or alkaline, or the poison is metal. You also need normal peristalsis because when you're giving this osmotic agent, you're going to go through the whole GI tract and it's going to be excreted in the feces. So you can have obstruction if a patient doesn't have normal peristalsis. So this is the three methods of decontamination. Um, Also in the D principle, so we talked about A, B, C, D. D is decontamination. Also, D is the don't combo. The don't combo is dextrose, oxygen, naloxone, and thiamine. And this is just a quick combo with minimal side effects to counteract hypoglycemia with dextrose. If patient is hypoxemic, you give them oxygen, and then naloxone if they overdosed on heroin or opioids, and thiamine if they're alcoholic. So you can give that combo even though you don't really know what is going on with the patient, because it counteracts some of the um, most common toxins that kind of cause the patient to be altered. The E in ABCDE is enhanced elimination. So how you enhance the elimination with the toxin is that you can dialyze the toxin, or you can manipulate the urinary pH. So, and we talked about this in previous lectures, is that you can acidify the urine for basic poisons or poisons that are alkalytic, or you can alkalinize the urine for acidic poisons. And the example of that is aspirin. Aspirin is an acidic drug. You give your sodium bicarbonate to alkalinize the urine, and it will be excreted. And then F is focused therapy. If there is any antidotes, specific antidotes for the poison that the patient has ingested. So A, B, C, D, E, F. This is an overview of the toxins that we're going to talk about. So we're going to talk about cholinergic toxins, or cholinergic toxidrome, anticholinergic toxidrome, sympathomimetics, narcotics, sedatives and hypnotics, acetaminophen, which we've talked about before, seafood, marijuana-like drugs, heavy metals, carbon monoxide, and other hemoglobin modifying agents, and then lastly solvents. So the first thing we're going to talk about is cholinergic toxidrome. And toxidrome just means a set of symptoms that are related to specific toxins. So cholinergic toxidrome is mainly because you have an increased acetylcholine. So think of it as too much parasympathetic nervous system. So the body is just chilling, but it's chilling too much. And the symptoms of cholinergic toxidromes is lots of secretions. So you remember the sludge mnemonic: salivation, lacrimation, urination, defecation, gastric upset, and I forgot the E. But anyways, you have a lot of secretions. You also hyperactive bowel sounds. You have bradycardia. And the key two things of the cholinergic toxidromes is meiosis and sweaty skin. I think of meiosis as the pupils are constricted because the body doesn't really need much light. It's sleeping, if you would say, or it's resting. So you have meiosis, and you have sweaty skin because you have lots of secretions. So what I want you to remember of the cholinergic toxidrome is three things: the sweaty skin, the meiosis, and the secretions. The toxins that are possible for the cholinergic toxidrome, there are kind of three different things. The first class is acetylcholinesterase inhibitors. So these come in different flavors. The first and the most important and the highly tested one are insecticides. And insecticides are organophosphates, and these are acetylcholinesterase inhibitors. So an example of test question would be: a patient who's a farmer comes to you. They have a lot of stomach upset. They're really sweaty, and you look at their pupil and it's constricted. What is happening with the patient? And what's happening is that they have an organophosphate toxicity. Also, another example which I didn't put here is the bioterrorist agents. They can use an irreversible organophosphates. So that's also an acetylcholinesterase inhibitor. Another acetylcholinesterase inhibitor is donepezil, and donepezil is a medication used for dementia and Alzheimer to increase acetylcholine in the synapses. And Donepezil, you can overdose on it and you can have a cholinergic toxidrome. And lastly, last of the acetylcholinesterase inhibitor is physostigmine, which is a medication called for myasthenia gravis. Actually, I apologize. Let me take a step back. I'm assuming that you all know what acetylcholinesterase inhibitors do, but in case you need a little refresher, so you have acetylcholine in the synapses, and acetylcholinesterase is the enzyme that's responsible for breaking acetylcholine in these synapses. So if you give an inhibitor to that enzyme, you're going to have too much acetylcholine in the synapses, and you're going to have uh, um, a cholinergic toxidrome, pretty much. So three things, most importantly, are the insecticides or the organophosphates, donepezil and physostigmine. So that's the first toxin that can cause cholinergic toxidrome. The second toxin is a cholinergic agonist called bethanechol, and that's a medication used for urinary retention. Um, and if patient overdoses on it, can get a cholinergic toxidrome. Nicotine is also, we know it goes after the nicotinic subtype of the acetylcholine receptor, but in large amounts of nicotine or nicotine toxicity, you can have a cholinergic toxidrome. The treatment for the cholinergic toxidrome is, that the basis is that you have too much acetylcholine. So the treatment is two things. First, you want to block this acetylcholine from binding, so you give an anticholinergic agent, mainly atropine. And atropine blocks the effects of acetylcholine. And then second, which is actually very, very important and very high yield, you give a medication that regenerates the acetylcholinesterase enzyme. And this medication is called pralidoxime or PAM, and that's specifically for organophosphates. And I guarantee you 100% that you will see this question on UWorld and maybe for some of you on step one. Very important to know that for a cholinergic toxicity, specifically the organophosphates, you give PAM plus atropine. Next toxidrome is the anticholinergic toxidrome. So anticholinergic means you just have decreased acetylcholine, and it's pretty much the opposite of the cholinergic toxidrome. So in this case, the patient is too dry. So you have flushed, dry skin, mental confusion because there is not much acetylcholine in the synapses. You have hyperthermia. It's kind of mimicking a sympathetic response, mydriasis, so the pupils are dilated, and tachycardia. The toxins that cause anticholinergics are a bunch, and mainly the biggest things that I want you to remember are the tricyclic antidepressants and the antihistamines. So tricyclic antidepressants, a classic example would be in a patient who's depressed that overdosed on tricyclic antidepressants. Antihistamines like diphenhydramine, a classic example would be an elderly patient who's taking diphenhydramine for sleep. Benzotropine is also an anticholinergic. It's used for Parkinson patients. Antipsychotics have also have anticholinergic side effects, and baclofen, which is a muscle relaxer, can cause an anticholinergic side effects. The treatment for anticholinergic toxidrome is to increase the acetylcholine in the synapses using physostigmine. So physostigmine, as we talked about in the earlier slide, is an acetylcholinesterase inhibitor. It inhibits the breakdown of acetylcholine in the synapses, and it'll treat the anticholinergic toxidrome. Also symptomatic management. Lastly, of these toxidromes, I wanted to talk about the sympathomimetic. So sympathetic, mimetic is mimic. And the sympathomimetic toxidrome is characterized by flushed, sweaty skin, mydriasis, and tachycardia. So I want you to pay attention to the difference between the sympathomimetic and the anticholinergic, because they both have the same, very, very similar presentation. Mydriasis and tachycardia for both anticholinergic and sympathomimetic. But the difference is in the anticholinergic toxidrome, you have dry skin. For the sympathomimetic toxidrome, you have sweaty skin. Think about it. If you're running from a bear, your skin is going to be sweaty. So that's how I kind of think about it. But it's very, very important to differentiate between the sympathomimetic and the anticholinergic. Toxins that cause sympathomimetic toxidrome is street drugs like cocaine, methamphetamine, and MDMA. These increase norepinephrine in the synapses. Amphetamine also, which is used for ADHD, and then MAO inhibitors, which inhibit the breakdown of monoamine neurotransmitters like norepinephrine or dopamine. The treatment for sympathomimetic toxidrome is symptomatic management, mainly benzodiazepines. So if you have a patient that's overdosed on cocaine and they're having these symptoms, you give them some lorazepam and they'll calm down. Specifically for cocaine, I want to remind you that you want to avoid beta blockers. And do you remember why you want to avoid beta blockers for cocaine toxicity? Because of the unopposed alpha effect. Remember that cocaine causes an increase in norepinephrine. Norepinephrine will go to the heart, stimulate the heart, cause tachycardia, and will also go to the blood vessels that have alpha receptors and will cause vasoconstriction. If you give beta blockers, specifically beta 1 or selective beta 1 blocker, it will go after the heart. It will block the effect of norepinephrine on the heart, but it will cause vasoconstriction in the blood vessels. And the clinical effect of that is that you have significant limb ischemia. So that is one high yield fact that I want you guys to be aware of. Next, so we talked about the toxidromes, the cholinergic, anticholinergic, and sympathomimetics. Next toxin that patients can abuse or can kind of overdose on is narcotics and sedatives, and these have similar symptoms. The narcotics, like the opioids or heroin, they cause CNS depression, respiratory depression, absent bowel sounds, and meiosis. You have a patient, the classic example of test question, 20 EMS brings a patient who's altered, respiratory rate is 6, and you check their pupils and they're constricted. What is the patient overdosed on? Or what is the treatment? So what the patient most likely overdosed on is heroin or opioids. And the treatment is mainly, first thing is respiratory support. So if the patient is not able to breathe, you intubate them. And then you give them an antidote, which is naloxone. However, remember that naloxone will precipitate withdrawal and agitation. So as soon as you give them that shot, the patient will get back up and screaming at you. So that is for narcotics. For sedatives, remember that sedatives work by increasing GABA. The symptoms of sedative overdose is CNS respiratory depression, but the biggest differentiation between the sedatives and the narcotics is that the sedatives overdose give the patient normal pupils, so the pupils are not constricted. Versus in narcotics, the pupils are constricted. Toxins for sedatives include benzodiazepines, barbiturates, and alcohol. Treatment is respiratory support, flumazenol if patient is overdosed on benzodiazepine, but remember that it can also precipitate withdrawal and seizures. For alcohol overdose, pretty much symptomatic support like benzodiazepine and thiamine. Next, two agents that we're going to talk about are acetaminophen and marijuana, specifically synthetic marijuana. Acetaminophen we've talked about before. Mechanism of injury or overdose is that the metabolite called NAPQI, which is acetaminophen metabolite, depletes glutathione. which forms toxic byproducts in the liver. The hallmark histology of acetaminophen overdose is central lobular necrosis, and that's something that's high yield for step one because it links pharmacology with histology. The symptoms for acetaminophen overdoses, or the clinical vignette will present you with a depressed patient with an overdose or suicide attempt. First 12 hours are nausea and vomiting. The next 12 hours, you have abdominal pain, right upper quadrant pain. 48 to 96 hours, you have jaundice and encephalopathy. And if it's not caught, then it can lead to fulminant liver failure by day 3. The treatment for it, as you know, is N-acetylcysteine, which regenerates glutathione. It can be given IV or oral, and it's best if given within the first 8 hours. Acetaminophen is very, very important to know because it can be very toxic, but also high yield for step one. Synthetic marijuana, which is called K2 spice, I guess. How it works is that it's a full cannabinoid agonist. It's 100 times more potent than regular marijuana. Symptoms for synthetic marijuana is conjunctival injection, increased appetite, or visual hallucination, which I guess you can't really differentiate it from regular marijuana. However, there has been recently in the news, and I don't know if this is going to be on your test or not, but it's important nonetheless. Synthetic marijuana have been associated with coagulopathy similar to Coumadin, and it's vitamin K dependent. So they found that patients um, can have bleeding, significant bleeding, and these patients respond to vitamin K, actually high doses of vitamin K. That I don't think that will be on your exam, but it's something that may be important for you when you go on your rotations. Treatment is supportive for synthetic marijuana. Our next toxin or group of toxins are seafood toxins, and these are not super high yield, but they have a couple interesting points that I would like to point out. The first toxin is ciguatoxin. It's found in dinoflagellate, which is reef fish. How it works is that it holds open voltage gated sodium channel. Ciguatoxin is important because it causes a funky symptom. It causes reversal of sensation, which is called ciguatera. Pretty much the patient will tell you, you'll put something cold on the patient and they'll tell you that it feels hot, or you put something hot on a patient and they'll tell you they feel cold. That's very, very classic for ciguatoxin. The treatment for it is supportive. And that's, maybe like one question or two questions on UWorld where you'll see. The next toxin is scombroid toxin, which is pretty much a histamine toxin. It's found in fish that's left out in the sun. And symptomatically, you'll find that many of the histamine effects, so rash, wheezing, bronchospasms, and it really mimics food allergy. Treatment is a histamine blocker, H1 and H2, and epinephrine if it's severe and if it's compromising airway. The last toxin is tetrodotoxin, TTX. It's found in puffer fish and it blocks sodium channels. It causes paralysis, cardiac and respiratory collapse, and treatment is supportive. Next group of toxins are the metals. And metals are interesting because they have specific antidotes, and that's what I wanted to kind of briefly talk about. The antidotes are called chelators, and chelators meaning that I'm going to bind to that metal. And there are some general principles for these chelators. There is 4 chelators that I would like you, 4/5 chelators that I would like you to know about. The first one is EDTA, which is editate calcium disodium. Editate calcium disodium. Um, Editate calcium disodium binds divalent ions. If you notice that there's 2 sodiums, the 2 sodiums go, and that binds divalent ions, mainly lead. So EDTA is mainly used for lead. It's excreted in the kidneys, so it's contraindicated in patients that are in renal failure or they don't make urine. The second chelator is succinimir, or dimercaprol. Dimercaprol is pretty much the IM form of succinimir. So dimercaprol is used intramuscularly. Succinylcholine is given orally. And succinylcholine sucks because it chelates heavy metals. So it's used for the heavy metals that suck. Uh, Lead, mercury, and arsenic. And it reverses in addition to that, it also reverses the inhibition of cysteine-containing enzymes. These heavy metal cause inhibition of these cysteine-containing enzymes, and succinylcholine or dimercaprol inhibit those. Third is penicillamine. Penicillamine forms complexes with targets and increases its solubilities. It forms complexes in three different states. The first thing, or the first state that penicillamine is used, it's also used for heavy metals like copper, lead, or mercury, mainly copper. Um, the second way that penicillamine is used is that it's used in cystinuria, and it binds with cysteine and it prevents cysteine stones. And then lastly, it's also used in rheumatoid arthritis, interestingly, because it binds with rheumatoid factor and increases its solubility. Side effect of penicillamine is penicillin allergy, because it's mainly a penicillin, and phremptothoma also causes membranous nephropathy. So it's something to remember. And then the last chelator that I want you guys to be aware of is defuroxamine, and that's used for iron toxicity. It binds free iron. So now, when we talked about the chelator, let's talk specifically about um, the heavy metal toxicity. So the first heavy metal that I wanted to talk about is lead, and lead is a divalent ion. Lead is an enzyme inhibitor. If you remember lead toxicity, how it works is that it inhibits heme synthesis. So it goes after two enzymes, furochelatase and ALA dehydratase, which are the second enzyme and the last enzyme in heme synthesis. It also inhibits ribosomal RNA degradation, which causes the basophilic stippling, uh, and it also interferes with cations actions, which is a unique thing to lead. Causes of lead toxicity is kids swallowing lead. So the classic clinical vignette will give you is like a patient who's living in a house that's built in 1948 that's coming to you with some symptoms of lead toxicity. Effects are of lead toxicity are lead lines on the gingiva and metaphysis of long bones. You also get microcytic anemia with basophilic stippling because lead inhibits heme synthesis, and you also get encephalopathy, which is the most important effect of heme. And I actually don't know what is the mechanism of encephalopathy because of lead. Treatment, as we talked about, are three different things. EDTA is the first treatment. Dimercaprol, you can give it intramuscularly, or you can give succinylcholine for children. Next metal that we're going to talk about is mercury, and mercury is also an enzyme inhibitor. It binds functional groups, which is something that's unique to mercury. Causes of mercury is lots of fish. Effects of it is gingivostomatitis. So you have inflammation of the gingiva if you have inflammation of your stomach. You also get tremor, and you have some neuropsychiatric symptoms. Treatment of mercury is succinylcholine first line and dimercaprol. Remember, succinylcholine and dimercaprol, these are the drugs for heavy metals. Arsenic is also an enzyme inhibitor. How it works is that it replaces the phos group, causes our contaminated water. The big thing in arsenic that I want you to be aware of is that it caused delayed peripheral neuropathy and severe gastroenteritis. So these are the two hallmark side effects of arsenic, delayed peripheral neuropathy and severe gastroenteritis. Also causes some QT prolongation. What is the treatment for arsenic? So arsenic is a heavy metal, so you use dimercaprol. Can you use succinylcholine? No, you can't, because succinylcholine is an oral agent and arsenic causes severe gastroenteritis, so patients are not going to tolerate succinylcholine. Next agent is copper. And copper, the biggest toxicity in copper is Wilson disease. And I want you to know the treatment is penicillamine. Next is iron. Iron toxicity works by peroxidation of membrane lipids and DNA oxidation. Causes of toxicity of iron is accidental ingestion by kids, transfusion in sickle cell patients, or hemochromatosis. Effects of iron toxicity is GI bleed and lethargy. And treatment is iron binding agents like IV deferoxamine, or there's the oral form of it is deferoxarox, and dialysis. So the three Ds: deferoxamine, deferoxarox, and dialysis. Lastly, I know it was mentioned in lecture, cesium and thallium. The antidote for it is Prussian blue, and I don't really know too much about it. Next agent for toxicity is solvents. You have different kinds of solvents. There is the aliphatic hydrocarbons and the aromatic hydrocarbons. The aliphatic hydrocarbons, these are halogenated. That means they have a halogen attached to it. They're mainly used as cleaning agents. They cause free radical injury. The biggest ones are the chloroform and the carbon tetrachloride. These cause CNS depression, cardiotoxicity, and liver injury. Carbon tetrachloride is also used in dry cleaning industry, and the high yield fact for carbon tetrachloride is that it causes liver central lobular necrosis. Do you also remember what did we talk about recently in this lecture that causes central lobular necrosis? Acetaminophen toxicity, yes. Treatment for hydrocarbons is removing the agent. Aromatic hydrocarbons, these are used as industrial solvents, benzene, toluene, and xylene. They have different effects. I don't know if much of it is really high yield, and I haven't really seen any questions on it, but something to gloss over. Lastly, I wanted to talk about something that is kind of high yield are agents that cause hemoglobin modifications. So these agents are mainly three things. Methemoglobin, which is hemoglobin that has 3 plus iron, carbon monoxide, and cyanide. So the first thing that we're going to talk about is methemoglobin. And the idea for methemoglobin is that hemoglobin that has 3 plus iron hates oxygen and doesn't really care to bind to it. The causes of methemoglobin is nitrites. So usually hemoglobin has 2 plus iron. When nitrites from diet or pollution get attack the hemoglobin, it oxidizes it to iron 3. Mechanism of action is iron 2 is oxidized to iron 3, which decreases hemoglobin oxygen binding capacity. What happens is that you get a left shift in the hemoglobin curve because the plus 3 iron can't really bind to oxygen. The rest of the hemoglobin becomes really stingy and causes a left shift in the hemoglobin curve. Symptoms for methemoglobinemia is cyanosis, chocolate blood, and interestingly, you have a normal PaO2. The treatment for methemoglobin is reduction of this iron. So you give methylene blue and vitamin C, which reduces the iron 3 to iron 2. Next hemoglobin modification agent is carbon monoxide. And carbon monoxide, what happens is that carbon goes and attack the hemoglobin, and the oxygen can't bind to the hemoglobin when carbon monoxide is bound. The causes of it is fire and car exhaust, and the product is carboxyhemoglobin, which is carbon monoxide and hemoglobin. So carbon monoxide binds to hemoglobin 200 times more than O2, and hemoglobin becomes really stingy and doesn't dissociate from oxygen. You also get a left shift in hemoglobin curve. Symptoms as opposed to methemoglobin and carbon monoxide, you get a cherry red skin. In methemoglobin, you get chocolate blood. You also have normal PaO2. The treatment for carbon monoxide toxicity is you give as much oxygen as possible. So you give 100% O2 You can also put a patient on hyperbaric O2. Lastly is cyanide toxicity. The idea in cyanide toxicity is the mitochondria can't use the oxygen to make ATP. Causes for it is smoke or plastic burning, also nitroprusside. Do you guys remember what is nitroprusside? So nitroprusside is an IV antihypertensive that is a vasodilator, and it's used in hypertensive emergency. Unfortunately, nitroprusside can cause cyanide toxicity. That's why we don't like to use it too much. Mechanism of action of cyanide toxicity is that cyanide binds and decrease cytochrome C in the mitochondria and block the electron transport chain and decrease oxidative phosphorylation. So it goes to the mitochondria and it blocks those enzymes. Um, and cyanide also binds methemoglobin. Symptoms for cyanide are toxicity are headache and seizures. The biggest thing that I want you to be aware of cyanide is high venous O2. Can you tell me why is there high venous O2 when cyanide uh, in cyanide toxicity? So the reason is because the mitochondria can't use the oxygen. The oxygen will be left in the venous system and you'll end up having high venous oxygen. As a result, you also have lactic acidosis because the mitochondria will resolve into anaerobic metabolism. Treatment for cyanide toxicity is two things. The first thing is to induce methemoglobinemia because methemoglobin actually binds stronger to cyanide than regular hemoglobin. So you induce methemoglobin with nitrites. You can also use thiosulfate. So that's the whole idea with hemoglobin modification. I hope that was helpful to you. This is just a summary for some of the toxins that we talked about. You can kind of read it on your own. So this concludes our section for the toxins or toxicology lecture. I know this was a lot for you. Go take a break. This is how I felt when I was studying for step one. So maybe remove some of those weights, go take a break, chill, and come back and review those. Again, as always, if you have any questions, please reach out to me or Mike, and we wish you guys all the best in your exam.